how do we evaluate that suspected intrinsic PEEP? First, remember that it should be suspected if the patient develops a very high respiratory rate and low tidal and generating a low tidal volume, high respiratory rate with low tidal volume, right? Especially in the background of patient being COPD or asthmatic patient, that is patient of obstructive lung disease. So it should be suspected. It should be suspected. It should be suspected if patient develops rapid breathing rate in association with high peak pressure, high peak airway pressure, right? High peak airway pressure, especially in the background of patient being a COPD patient and asthma patient. And remember, if these things are happening and patient has also developed hypotension, then this is a sign of worsening, right? So always we need to manage before this worsening sign comes. Okay, so what are the ways? One I said is your non-quantitative method, or we call it the qualitative, let's say with the help of ventricular graphics. So non-quantitative method, in which we cannot actually calculate how much is the intrinsic PEEP. We can just see that there is an intrinsic PEEP. So non-quantitative method, which is by the ventilator graphics, and frankly this is the more common way what we are analyzing the intrinsic PEEP. So this is more commonly, and we are using the ventilator graphics, and we have to see the flow time graph, and also along with, when you see the flow time graph, use palpation or auscultation method. By auscultation we can see that before the expiration is finishing, the next inspiration has started of the patient by auscultation. So airflow would be heard, expiratory airflow would be heard before, let's say, would be heard, and another inspiratory breath would be started. So flow time graph and palpation or auscultation, right? So what we see, inspiratory airflow starts, is heard before expiration stops, So inspiration starts before expiration stops. So if you see this graph, the upper one, this is the flow time graph, So this is the inspiratory flow, this is the expiratory. So inspiratory flow, inspiratory flow, and now expiration has started. So expiration, before it touches the baseline, the next inspiration has started. You know, before it touches the baseline, the inspiration should touch the baseline like this. The red line which I had just drawn, it should touch the baseline, and then the inspiration should start. So expiration should touch the baseline, the expiratory flow should touch the baseline before inspiration start. So what is happening in flow time graph? This is your inspiration, the expiration starts, and the expiration does not touch the baseline. The expiratory gas airflow has not stopped, it has not touched the baseline. It has to touch the baseline, it has not touched the baseline, and before that the second inspiration starts. So again the second inspiration, and again the expiration starts, but it does not touch the baseline, right? So all this is leading to the accumulation of air. Okay, so we have to see the flow time graph very carefully, and just by seeing the flow time graph we will get an idea that incomplete exhalation is happening, and incomplete exhalation is leading to air trapping and causing the intrinsic PEEP, So this is your non-quantitative method, non-quantitative method. Now let us say non-quantitative method. Now let us talk about quantitative method. How do we calculate this intrinsic PEEP? By something called quantitative method, right? So quantitative method is by airway pressure, measuring the airway pressure at end expiration. Airway pressure right, at end expiration, at expiratory pause, right. So let us first understand, then again I'll come on this graph. So intrinsic PEEP, what is the formula to calculate the intrinsic PEEP? Intrinsic PEEP. Now intrinsic PEEP is equal to end expiratory pressure, minus the applied PEEP, end expiratory pressure minus applied PEEP, right. So intrinsic PEEP to calculate by this method should be less than 10 centimeter of water, then only we can calculate it, and it will only be accurate if the patient is paralyzed. So in every ventilator there is an expiratory hold button. We press that button for 1 minute, and this brings the patient in an expiratory hold, and this, at this point of time, whatever is the end expiratory pressure, we see that end expiratory pressure, subtract the applied PEEP, and that is what is your intrinsic PEEP. And this would only be accurate if developed intrinsic PEEP is less than 10 centimeter of water and patient is paralyzed. Okay, right. So this is the quantitative method. So if you can see, at the end expiratory pressure, at the end expiration, on pressing the button end expiratory pause, we can calculate this intrinsic PEEP with the airway pressure, whatever is the airway pressure. This airway pressure we measure, subtract it with the intrinsic PEEP, the applied PEEP, and we get this intrinsic PEEP. Value. So here there is an end expiratory hold. There is a hold at the end expiration. Okay, so no volume, no air is moving. So this at end expiratory hold, you see this 3 graphs. When you press this button, your eyes should be on these 3 graphs. There should be no flow of air. There should no volume passing through the lung. And at this point of time, whatever is the intrinsic PEEP, the pressure which is calculated, by which we will get an idea of intrinsic PEEP of the patient, right? Now, this is not a very accurate method. This requires the intrinsic PEEP not to be very high, and this requires a complete paralysis of the patient. Patient should not have any effort. There should be no diaphragmatic movement of the patient. Otherwise, the calculation would not be correct. So complete paralysis is required. Not very commonly used method because it doesn't give a very accurate result. Though most of the ventilator today have the expiratory pause mechanism available in them to calculate the intrinsic PEEP. But studies have shown that it is not very reliable. Okay, now let us see what are the causes of intrinsic PEEP. Coming on the causes, why this breath stacking happens. Now, if we know the causes, then only we can manage. Breath stacking is happening because of the tidal volume, expiratory tidal volume not being achieved, the air getting trapped in the alveoli. So it could be due to high minute ventilation, right? It could be due to low expiratory time, right? So minute ventilation is one thing that we have to look for. So causes could be high minute ventilation, or expiratory flow limitation, as in COPD and asthma patient, expiratory flow limitation, and increased expiratory resistance due to the issues with device, tubes, etc. So increased expiratory resistance, right? It could be due to these 3 causes, and in one patient, more than one cause may be there. A patient with expiratory flow limitation may develop high minute ventilation, and this would result in air trapping. So in most of the patient, cause is more than one, and it can be determined. It can be determined by seeing the graphics of the patient. So if we see the graphics of the ventilator, right, we can determine what is the major cause leading to the trapping of the air in the alveoli or development of intrinsic PEEP. Now, you need to pay attention in this increased expiratory resistance. Now, this is a reversible cause of air trapping, and we need to rule out in every patient this increased expiratory resistance to the breathing, because this is something which we can reverse. Okay, now let us see high minute ventilation. How does it affect? So high minute ventilation. High minute ventilation means the tidal volume is more, so increased tidal volume. So this increased tidal volume, this would result in incomplete exhalation, right, before the next breath. So one way to counteract the intrinsic PEEP would be if we decrease the tidal volume. So keep it in mind. Okay, then the next is the increased respiratory rate. If respiratory rate is more, then what will happen? The expiratory time, the duration would decrease. So again, it will cause air trapping. So the other way of combating the intrinsic PEEP is by decreasing the respiratory rate. Okay, so remember, we should be very crystal clear in our diagnosis that if there is an airflow limitation, the airflow limitation is due to the lung disease. It is not due to increased expiratory resistance caused by the equipments. So if you see this diagram, then let's say this is a choke point, the first figure and the second figure. Now in both, hyperinflation is happening, but in the first figure the hyperinflation is happening due to lung disease. In the first figure, the hyperinflation is happening due to lung disease. This is the obstruction point or the choke point. This is preventing the air to go out, preventing the air to empty, right? And if you see, this is a second figure, is hyperinflation without the lung disease. Here the resistance is at the level of the expiratory valve or at the level of the bacterial filter, at the level of the tube, which is causing incomplete exhalation, and this is causing the hyperinflation. So in case of hyperinflation without airway obstruction, if you apply the extrinsic PEEP to counteract the intrinsic PEEP, that can be deleterious, right? That can be deleterious. So we have to rule out any obstruction due to increased resistance in the equipment and all, right? Hyperinflation with airway obstruction, definitely the work of breathing will decrease if we apply extrinsic PEEP, right, to counteract the intrinsic PEEP, but not in this case. So we have to rule out this. Okay, so these are the three important causes of developing the intrinsic PEEP. When the minute ventilation is very high, then expiratory flow limitation and increased expiratory resistance. Okay, and we need to manage each of the following, making the diagnosis, and by seeing the graphics of the ventilator, we would get a very good idea that what is the cause of this air trapping. Okay. Now let's talk about the treatment. Management, treatment. Now treatment we can divide into two parts. I would show you a flow chart how do we manage, but we can divide it into two parts. Life threatening, if it is life threatening, or if it's non-life threatening. So if it is causing life threatening symptoms, or if it is non-life threatening, right? So we will talk about both life threatening and non-life threatening. Let's go through the flow chart of management, treatment, and then one by one I'll discuss. So we have a suspicion of intrinsic PEEP. If patient is taking rapid breathing rate, patient is in respiratory distress, there's a ventilator dyssynchrony, and there's an expiratory wheeze. So whenever the minute ventilation is very high, rapid shallow breathing, patient is in respiratory distress, ventilator dyssynchrony, and there is a wheeze, expiratory wheeze, we should suspect the intrinsic PEEP being developed. Now we can confirm the portable intrinsic PEEP with the following ventilator findings. How can we confirm that intrinsic PEEP has developed? We see the elevated peak pressure on volume control mode and small tidal volume in pressure mode. So in volume control, very high pressure, and in pressure control, a very low tidal volume will be achieved. And expiratory flow fails to reach the baseline in flow time graph. So if I show you this, again the same thing I'm repeating, the expiratory flow is not touching the baseline. The expiratory flow should touch the baseline, but it is not touching the baseline, right? So this would give us an idea that most probably intrinsic PEEP has developed. So if intrinsic PEEP has developed, right? Now, if it's associated with life-threatening features like hypotension, etc., what should we do? Immediately we should disconnect the patient from ventilator. So if intrinsic PEEP is immediately life-threatening, what is the life-threatening things? High elevated pressure more than 40, or rapidly rising the pressure in volume mode and rapidly reducing tidal volume in pressure mode, or hypotension. A very high pressure is generated on the ventilator, right? Very high pressure is generated, more than 40, 50, and very low tidal volume in case of pressure time graph, and very high pressure in case of volume time graph. Or patient develops hypotension. What we do? We immediately disconnect the ventilator from the endotracheal tube, and we keep it disconnected for 15 to 30 seconds. This will remove that intrinsic PEEP. If hypotension improves when we do this maneuver, then definitely, right, and the airway pressure lowers, after reconnection, then definitely it was intrinsic PEEP, and it was life-threatening intrinsic PEEP. If this doesn't happen, the hypotension doesn't improve and the airway pressure doesn't decrease, we have to look for the other causes and then come back on finding whether it's intrinsic PEEP really or not. I mean, then intrinsic PEEP is not confirmed. Okay, if patient improves on these maneuver, then we try to treat the reversible cause of the intrinsic PEEP. So what are the reversible cause of intrinsic PEEP? The reversible cause of intrinsic PEEP, now this chart, if patient is having some pain, anxiety, or is in delirium, his minute ventilation will increase. So in case we treat these things, we treat the pain, we manage the delirium, we give appropriate sedation to the patient. If patient has acute bronchospasm, we give bronchodilators, steroids, right? Then if mucus impaction or secretions are there, obstruction is happening, then aggressive suctioning or bronchoscopy clearance should be done. Kinked or small artificial airway, we should change the artificial airway. Faulty ventilator circuit component, we should replace it. And extrinsic compression due to tumor, we should manage with discussion with the multidisciplinary units. So you can see now these last four causes, this is not due to the lung disease. The airflow limitation is not because of lung disease, it is because of obstruction. So these are kind of reversible, technically reversible, and we should rule out these things before managing the intrinsic PEEP with extrinsic PEEP. Now acute bronchospasm is one of the common cause of intrinsic PEEP. It should be treated immediately with bronchodilators and steroids, and any pain, anxiety, etc. in the patient should be treated. So these are the, let's say, reversible cause of intrinsic PEEP. So we try to find out the cause and try to treat it. Other things which we can do the changes in the settings of ventilator. So we can adjust the ventilator setting by reducing what would cause the intrinsic PEEP? High minute ventilation. So we have to decrease the minute ventilation. So we reduce the respiratory rate to give more expiratory time, and we reduce the tidal volume. And this will decrease the tidal volume, and this will cause a less tidal volume going into the alveoli. So chances of complete exhalation would be there. So we have to decrease the tidal volume and respiratory rate. Now remember, if patient is on volume control mode, we will decrease the tidal volume. If patient is on pressure control mode, we will decrease the pressure, right? Pressure which we have set to decrease the tidal volume which is being achieved by the patient. Okay. Now target is that plateau pressure should be below 30, pH should be above 7.2, acidosis also not should develop, and intrinsic PEEP should be less than 10. Now if the targets are achieved, no further management is required. If target is not achieved, then we can reduce the inspiratory time flow. We can give the inspiratory flow flow more faster to the patient. So what will it do? It will again increase the expiratory time of the patient. So reduce the TI. The TI is reduced. That is the time in which the inspiratory flow is given to the patient, right? By increasing the inspiratory flow in volume mode, or by in inspiratory expiratory time, inspiratory expiratory ratio in pressure mode. Target is again the plateau pressure less than 30, pH should be above 7.2. If with these changes the ventilator target is achieved, first we decrease the minute ventilation, then we are changing the I ratio or the inspiratory time, right? If it is achieved, again nothing has to be done. If this is not achieved, then we need to see whether the patient is optimally sedated or not, because these ventilator parameters would not be achieved if patient is not optimally sedated. So we can consider the sedation or neuromuscular blockade in the patient, right? So if patient is not receiving a high sedation or neuromuscular blockade, we should consider of using these, or we should change little bit more in the ventilator setting, reduce the flow trigger from the set level. So if flow trigger is at 2 liter per minute, we reduce it from the set level to -7 to 1 liter per minute to decrease the work of breathing, and we can increase the flow trigger from the set level for excessive auto triggering. So we try to set the ventilator, we do the ventilator adjustment by seeing whether it is ineffective triggering or auto triggering. And if patient has any underlying airway disease, we try to treat it, right? And then even if it's not improving with all these maneuver, then we should try to decrease the work of breathing of patient by applying the extrinsic PEEP. So we should apply the extrinsic PEEP, increase the extrinsic PEEP to the 50% of the intrinsic PEEP. It should be not more than intrinsic PEEP, it should be 50% of the intrinsic PEEP or less than 80% of the intrinsic PEEP, right? This will decrease the work of breathing of the patient, right? And all this we have to optimize the ventilator setting as I have just now discussed, and treat the underlying cause. So this is how we manage the intrinsic PEEP if it has developed step by step. So I will again discuss all the steps which I discussed. If it is life-threatening means it is suspected in an intubated patient with a very high pressure being generated and very rapid shallow breathing, high minute ventilation, low tidal volume, increased respiratory rate, and very high pressure. All this in a background of COPD especially, we should think about it is the intrinsic PEEP being dynamic hyperinflation being developed. So if it is being developed, what should we do? If it is life-threatening, that is a very high airway pressure being achieved and hypotension, immediately we have to disconnect the circuit, stop the ventilator, disconnect the circuit for 15 to 20 seconds. Then again we need to reconnect, and on reconnection, if the airway pressure is not increasing, not shooting as it was earlier, then definitely it was intrinsic PEEP. The diagnosis is kind of confirmed. Hypotension improved, diagnosis is kind of confirmed. So we suspect. What do we do in the life-threatening case? What is the life-threatening condition? Is rising peak pressure, very rapidly rising peak airway pressure, and hypotension developing, hypotension. So in this case, we disconnect the ventilator. We disconnect the endotracheal tube from ventilator, right? For 15 to 20 seconds, right? And after attachment, the airway pressure should decrease and hypotension should improve. If this is happening, definitely the diagnosis is confirmed and we have resolved the life-threatening condition. Life-threatening were these two. After achieving this, we will manage as non-life-threatening condition. So non-life-threatening condition. So non-life-threatening, we have to do the ventilatory setting management. So as I have already discussed, we have to address the reversible cause, etiology. So reversible etiology I have already discussed. The reversible etiology are your pain, anxiety, right? All this causing increase in minute ventilation, then inadequate sedation, all these causing increase in minute ventilation, then bronchospasm, bronchospasm, so which we have to treat it with steroids and bronchodilators, or extrinsic or occlusion of the airway, instruction of the airway, like by mucus. So bronchoscopy, will do a bronchoscopy, try to clear the mucus, or any kinking of the tube, kinking of the airway circuit and tube. All these we have to look for, and we have to treat it. Now then if this is not let's say improving more, then we have to change the ventilatory strategy. We have to adjust the ventilator adjustments. So what adjustment we do? We do the adjustment on the tidal volume and on the expiratory time, the expiration time. We have to increase the expiration time and we have to decrease the tidal volume, right? So how do we decrease the tidal volume? We have to decrease the tidal volume by doing the setting. In case of volume control ventilation, simply we have to decrease the set tidal volume. In case of pressure control ventilation, we have to decrease the pressure, set pressure, right? And target should be that pH we can maintain above equal to 7.2. See, you cannot let the respiratory acidosis also to happen. So target is pH more than 7.2, the plateau pressure less than 30 centimeter of water, and inspiratory PEEP should be the intrinsic PEEP. The intrinsic PEEP should be achieved less than 10 centimeter of water, right? So we have to decrease the tidal volume. So how do we do? Simply by decreasing the tidal volume and by reducing the respiratory rate of the patient. So these are the two adjustments we have to do. We have to increase the expiratory time by decreasing the respiratory rate, and we have to decrease the tidal volume. So all this will decrease the minute ventilation. If this is not doing the job, then the second step is to reduce the time for the inspiratory flow. If we reduce the time for the inspiratory flow, more time would be given to the expiration. So expiratory time will increase in volume control, right? And in case of pressure control, IE ratio has to be changed. So the second setting would be reducing the inspiratory time. So how we can do by reducing the inspiratory time? By shortening the TI in volume control ventilation, and we can change the IE ratio, let's say from 1:2 to 1:4, more time given to expiration. So this is the second thing which we can do. Then what we can do? We can if the PEEP, let's say your intrinsic PEEP is persistent, right? Then if already, triggering, how do you choose the trigger? The trigger generally nowadays, what is preferred is flow trigger. Now this is always a preferred thing. If by somehow pressure trigger has been chosen by you, change it to flow trigger, and try to set the flow trigger at the lowest level. Try to set it at lowest level to initiate breath, right? Now it should be always be careful that lowest level to initiate breath, this should not cause the auto triggering. Now studies have shown 0.7 to 1 liter per minute can be optimal in these patients, right? Then still the intrinsic PEEP is not getting let's say straight. What we do to decrease the work of breathing of the patient? We apply the extrinsic PEEP. So we apply the PEEP, application of extrinsic PEEP. So how do we do? Now we have this much Auto-PEEP. If we keep the extrinsic PEEP 0, the patient has to overcome this Auto-PEEP to generate a breath. So work of breathing will increase. So if let's say Auto-PEEP and we have set the external PEEP at the level of Auto-PEEP or below the Auto-PEEP, the work of breathing will decrease, right? So the target is that your Auto-PEEP, when there is an Auto-PEEP, inspiratory PEEP, when there is intrinsic PEEP, then extrinsic PEEP or ventilator PEEP should be between 50 to 80%, less than 80%. of intrinsic PEEP, intrinsic PEEP, more than 80% has shown to increase the dynamic hyperinflation, right? More, it will cause the dynamic hyperinflation. So it should be between 50 to less than 80%. If you will keep the PEEP higher than the intrinsic PEEP, then the net PEEP will overall increase. So further, it will cause hyperinflation in the patient, right? So it should never be done that extrinsic PEEP should be above the intrinsic PEEP. It should be between 50 to less than 80%. So this is the setting which we do, okay? So we calculate the intrinsic PEEP, and 50%, 50 to 80% of the intrinsic PEEP is what we do in the setting of extrinsic PEEP, right? To decrease the work of breathing. And how do we calculate? Already I have told you, there's the expiratory hold maneuver provided in the ventilator. We press that button for, let's say, 1 minute, and we get a airway pressure. We subtract that peak pressure from that peak pressure at that point of time with the applied PEEP of the ventilator, and we get the intrinsic PEEP. So at expiratory hold, right, whatever is the peak pressure, we subtract it from the extrinsic PEEP and we get intrinsic PEEP. So we calculate it, we keep the extrinsic PEEP 50 to 80% of the intrinsic PEEP, the work of breathing will decrease. So this is how we calculate the intrinsic PEEP, right? And we do the setting of extrinsic PEEP and manage the intrinsic PEEP or dynamic hyperinflation. These are the management, but we have to do the ultimate cure of the problem which is causing the intrinsic PEEP. So if it's bronchospasm, treat bronchospasm. If it's extrinsic compression, treat extrinsic compression. If it's the reversible cause which we talked about, treat the reversible cause. Then you will get a better result. Okay. So this is how we manage intrinsic PEEP, and this is all about PEEP which I wanted to discuss. I hope you have understood. Thank you.